endocrine physiology, parathyroid hormone, and calcitonin. All right, so for parathyroid hormone, what you have to understand is that they're produced by chief cells of the parathyroid. And the question is, where are the parathyroid glands? On the thyroid gland, there's these 4 small dots, okay? And those 4 small dots are these glands that help with calcium homeostasis, okay? And they produce parathyroid hormone in order to help with this calcium homeostasis. So PTH are produced by chief cells of the parathyroid gland, all right? Now, the whole function, the whole point of PTH is to increase free calcium within the blood. So if we notice that there's decreased calcium in the blood, our receptors at the parathyroid gland are going to sense it and they're going to produce PTH in order to increase the total amount of calcium within the blood. And how does it do that? Well, it increases calcium absorption in the GI system, it increases calcium absorption from the bone, and it increases calcium reabsorption in the kidneys at the DCT. Okay, we already discussed that in the renal pathology. All right, so while doing that though, it also increases phosphate absorption in the GI system and the bone resorption, but it decreases phosphate reabsorption in the PCT. And that's a very key factor for PTH as well. So although it increases calcium and phosphate reabsorption at the GI system and the bones, it will do opposite effects at the kidney. So it will increase calcium reabsorption in the DCT, but it will trash phosphate at the PCT, leading to a decrease in reabsorption of phosphate. Okay? And the last function that it has, which is very important, is that it will activate 1-alpha hydroxylase at the kidneys to form activated vitamin D, also known as calcitriol. Okay? Now, just like GnRH, parathyroid hormone has differences whether it's intermittent or continuous. An intermittent release of PTH will lead to an overall increase in bone formation because it stimulates osteoblast activity, and that's a very important concept, okay? Because normally it's released continuously in our body in order for it to have a bone resorption effect. But if we give intermittent doses of PTH, then it actually has an increase in bone formation. It's good for the bone. All right? So keep that in the back of your mind. An intermittent amount of PTH release will lead to an increase in bone formation because it stimulates osteoblasts, which build the bone. Okay? Now, there's also this thing known as rank L. Rank L, it's known as receptor activator of NF-kappa B ligand. They like you to know that. Okay? PTH increases rank L secreted by osteoblasts and osteocytes. Okay? And what that does is it binds rank, which is a receptor on osteoclasts, and it stimulates osteoclasts and overall increase in calcium due to bone resorption. Okay? So the question is, why does PTH allow for an increase in calcium and phosphate from bone resorption? It's due to the fact that it increases rank L production. Rank L production leads to an overall stimulation of osteoclasts, which break down bone, and osteoclasts are going to lead to an increase in calcium because we have bone resorption. Now, remember, once again, there's a little trick here. If it's intermittent PTH, then it has the opposite effect. It will cause bone formation, and it won't have an increase in rank L. Okay, very important to differentiate those two. Lastly, there's this thing known as PTHRP, which is PTH-related peptide, and it functions exactly like PTH, and it's commonly found in malignancies. So we can see our squamous cell carcinomas of the lung as well as renal cell carcinoma producing PTHRP, and we've covered both of those. Okay? So you can see increase in calcium in the blood secondary to a malignancy due to the fact that we have PTH-related peptides floating around. Now, how do we regulate PTH? Well, if we have decrease in serum calcium, we have increased PTH. And then opposite occurs, right? So if we have an increase in serum calcium, then we have a decrease in PTH because there's no need. If we have increase in serum phosphate, we also have an increase in PTH, and that's very key to understanding, okay? But that's all for PTH, a very important hormone that you need to know. Next is calcitonin. Calcitonin, all it does is it lowers serum calcium, okay, used in hypercalcemic patients, okay? So it tones down the calcium levels. It's released from the parafollicular cells, the C cells of the thyroid, and that's all that it does, okay? And the way that it does it is it inhibits osteoclastic bone resorption. So remember that whenever we need calcium from the bone, we're going to have to activate osteoclasts. And whenever we don't want calcium from the bones, we have to inhibit osteoclasts. Okay, very key concept. Osteoclasts clash down bone. Osteoblasts build up bone. All right? Calcitonin is pretty much never asked about. So that's pretty much all you need to know for a calcium homeostasis between PTH and calcitonin.